Good morning, my dear students and teachers. We are going to start our yearly program, AOI West Bengal yearly program, PG Orient 2023. This program is mainly for the postgraduate student for their practical orientation how to face the practical and Viva exam, mainly focus on that. So we start today's first program. Uh, Dr. Ramanuj Sinha sir, please come on the. Dr. Somendranath Bandyopadhyay sir, please come. Dr. Arindam Das and Dr. Bibhas Adhikari, please come on the dais. So you already know the first topic. The chronic otitis media, you are getting long case in your exam. So this is the first case of a discussion today. We will start the program. Hand over to Dr. Somendranath Bandyopadhyay.
Good morning, students. We are somewhat late in starting the program. So I will go straight into the program. Today, the first session will be on chronic otitis media. The first session will be on chronic otitis media, and the session will be moderated by Professor Ramanuj Sinha, Professor Bibhas Adhikari, Dr. Arindam Das, and me, Dr. Bandyopadhyay. So hope you all are comfortable with Bengali, and if you find it difficult to follow what we want to say, don't hesitate to tell us that you could not understand it. So in that way, it will be easier for you to make the best of this session. Chronic otitis media is nothing new, and you have read about and discussed about chronic otitis media from the very first day of your course curriculum. So we have changed our approach this time. Till the last year, we preferred didactic approach. So we tried to teach on PowerPoint presentations and talking about something that may be important for the exams. But this time, we want to make it more interactive. So we will take lesser time on our part and ask questions or your doubts to be cleared in the next half of the session. So first up, we will tell you something about the way we want you to approach a case of COM. So chronic otitis media, most often it will be your long case. If it is available, it will be the long case, and you, if you can do well in the long case, you are almost sure to pass. So you must be very careful about how you present your long case. Chronic otitis media, I will first discuss about the presentation and history part. Then the workup will be discussed by Dr. Arindam Das, and then the surgical approach and the audiometry part will be discussed by Professor Ramanuj Sinha, and Dr. Bibhas Adhikari will give you some tips about some important points about chronic otitis media. So regarding history, how the patient presents. Whenever you are writing a history, you know how to write a history, nothing to say about that. But whenever you write a history, from the very first moment you know your diagnosis. What is your diagnosis? And every part will suggest points in favor of your diagnosis. So, history, the patient particulars. Now, the history of present illness. For chronic otitis media, it is almost always regarding the symptoms, the progress, and the previous treatments, if it is not associated with any complication like labyrinthitis, dizziness, or facial palsy, like that. So it will be symptoms, progression, and previous treatments. Symptoms. Don't discuss about the other symptoms that may complicate your diagnosis. Most often it will be chronic otitis media, your long case, and chronic otitis media, squamous disease, your long case. So squamous disease. We will go straight to the squamous disease. 2 complaints, deafness and discharge. So the patient will complain of hardness of hearing or shortness of hearing, or the patient will say that I cannot understand the speech. So something like that. So these are the 2 complaints that you must write, and don't go into other less important details. And these 2 points, chief complaints, surprisingly in DNB exam also we find that the students, the examinees, they don't know how to write the chief complaints. Chief complaints are the main complaints the patient have, dash with duration, not a sentence. So difficulty in hearing, dash, 5 years. Recurrent discharge from the left ear, say 1 year, 5 years. So it will be in chronological order. The symptom that is present for the longest duration should come first, and only the symptom dash duration. Now you elaborate in history of present illness and start from the onset. Start from the onset. Onset, progression, then you will have to characterize the discharge that we often miss. Characterizing the discharge. Whether it is profuse or scanty, it is purulent or mucopurulent, blood stained or not, foul smelled or not foul smelled, what is the color of the discharge. So these are the basic things you must write. The character of the discharge, duration of the discharge, how it fluctuates, how the symptoms improve and deteriorates, or there is no change and it continues progressing. Past history. If you find any suggestive past history, before the universal immunization program, the measles were a serious culprit, an important culprit in causation of chronic otitis media. But now it is most often it is insidious in onset, and the patient does not know what to, where from the disease started and from when the disease started. So history, every point must direct to your diagnosis. What are the points in favor of your diagnosis should be highlighted. So this is the thing. Another is, when you document your findings, it should be very precise and directed to your diagnosis. Now another important point is that how to draw the diagram of your tympanic membrane. Left and right. What will be the tilt of the handle of malleus? So these are the structures. A tympanic membrane, diagram of a tympanic membrane, that is in 50% of the answer scripts we find the diagram to be drawn wrongly. So এইটাকে একটু দেখে নেবে যে drawing a diagram is very important. Whenever you are drawing a perforation or a retraction pocket or an abnormality, that will have its effect on other parts of the tympanic membrane and also on the other ear. So drawing a diagram of the tympanic membrane is very important, and you must know how to draw a diagram. Scott Brown খুব ভালো ডায়াগ্রাম আছে, কোনো অসুবিধে নেই। তোমাকে ডায়াগ্রামটা কিন্তু ঠিক করে আঁকতে হবে, ডোন্ট মেক ইট কমপ্লিকেটেড। ডায়াগ্রাম, annulus, pars tensa, anterior posterior malleolar folds, handle of malleus, short process of malleus and the attic region. তো এই ডায়াগ্রামটা একটু ঠিকভাবে আঁকবে, এবং রাইট, লেফট, ওয়েবার, রিনি is positive or negative, ওয়েবার lateralized or not lateralized, absolute bone conduction test is reduced or not reduced. ভেস্টিবুলার টেস্ট করতে ভুলবে না। নাকের হিস্ট্রি লেখার সময়, নেজাল কেসের হিস্ট্রি লেখার সময় কোল্ড স্প্যাচুলা টেস্ট আমরা ভুলে যাই, আর ইয়ারের হিস্ট্রি লেখার সময় ফেশিয়াল নার্ভটা লিখতে ভুলে যাই। সো remember to write about the condition of the facial nerve. So this is how a patient presents, though most often it is discharge and deafness, but the patient usually presents with deafness, even if there is discharge. Now, when the discharge is scanty and when the discharge is profuse, when you do say, this is scanty discharge, no discharge, profuse discharge, when do you say a discharge to be profuse? When do you say a discharge to be scanty? If there is discharge, if there is crusting, you will have to clean it. How do you clean the ear? How do you toilet the ear? You must be very clear about that. When the discharge is coming out of the introitus, it is profuse discharge. When it is inside the ear or just there are some crusts, it is scanty discharge. So if the discharge comes out, it is profuse or it is scanty, and then it is foul smelling, blood stained, all these points should be written. So this is how you come to a diagnosis. And what is the diagnosis? No short forms, not COM. It is chronic otitis media of the left ear or right ear or both ears. What is the type of the disease? It is squamous disease or mucosal disease. In which stage? Whether it is active or inactive. What is the type of deafness? Not the type of perforation. We don't want to know the type of perforation in the diagnosis. But type of perforation will guide you to the diagnosis. So, chronic otitis media of the left ear, squamous disease in the active stage with conductive hearing loss and without any complication. So, the diagnosis should be complete. Now, the examiner will ask one by one, what are the points in favor if you are diagnosing it in this way. And every part of the answer script, every part of your history will be checked in this way. You can check the answer script yourself. You can keep the history with yourself. It is your property. It is not that you will have to memorize everything and tell the examiner, because whatever you have written here is your property, your notes. And your notes will be consulted by you to come to a diagnosis and tell about the situation. So, it is, you can always ask for the paper to consult before you answer the questions of the examiner. So, now how will you proceed? So, you have written a history, there is a diagnosis, now how to proceed? What will be the workup to go for a proper management? I will ask Dr. Das to elaborate on that.
Thank you. Good morning, everybody. It's a fine discussion regarding the COSM case. First, we have discussed how to take the history. Then, what are the points we should examine before going for the provisional diagnosis. So, the examination of the ear, nose and throat, one by one. So, for ear, sir has been described. So, what are the points we have to note during the clinical examination. After the clinical examination is over, you have reached a provisional diagnosis. Suppose this is a case of chronic otitis media with squamous variety. And now, one point I want to mention, that in any case of COM, that is squamous disease, invariably the mucosa will be hypertrophied or maybe in an active stage. So, always in case of cholesteatoma, there will be a dual pathology. So, don't confuse. If there is a cholesteatoma, that should be go with the squamous disease, because if there is active cholesteatoma of the squamous disease, invariably the mucosa will be inflamed and the mucosal disease also be at the same point of time. So, that will be your provisional diagnosis. But before going for the definitive treatment, whether surgical or maybe the medical management, you should go for some workup, some investigations. So, what are the investigations we have to do before going for a management for the patient? So, whenever we ask the questions, majority of us, we want to start the blood investigation, hemoglobin T, CTCs or whatever. No, this is not actually the case. When you were going for a COSM case and examiner asked you for the workup or the examination, then first try to elaborate the investigation that will stamp the diagnosis. So, first is the examination under microscope, UM. Examination under microscope is the gold standard investigation for COM that has been written in Scott Brown. You can take the reference from there. So first is the examination under microscope. What are the things you will actually see in examination under microscope? First, suction and clearance. You will clear any debris from the external auditory canal to visualize the tympanic membrane and diagnose or try to diagnose the pathology, whether it is in the pars tensa or in the pars flaccida. Why this suction irrigation or microscopy is important? Not only to magnify the images, but remove the small crusting, because the actual disease may be hide behind the crusting or the disease. Because if there is a, suppose a attic cholesteatoma, sometime in otoscopy or in bullseye lump examination, we see there is a small crusting in the attic region, but no cholesterol flakes or no cholesteatoma debris has been seen. So it's very difficult to stamp the diagnosis as attic perforation or COM or cholesteatoma, and in that cases, this microscopy and suction clearance is important to diagnose properly. Second, examination of the pars tensa and its retraction. Whether the retraction is grade 3, grade 4, or in a attic perforation is a stage 3, stage 4, whether the fundus can be seen or not, that can be easily evaluated using the microscope. So always start your examination with examination under microscope. Now the second part is, nowadays with the advent of endoscopy, examination under endoscope or preoperative diagnostic endoscopy is also a important investigations, because in some cases if there is attic retraction or attic perforation, you cannot actually visualize the depth of the sac or the fundus of the sac. You can negotiate a 2.7 millimeter endoscope up to the attic and can visualize the sac completely. At the same point of time, if there is a posterior superior retraction, the ossicular chain status is better visualized using a endoscope. So this is the microscopy and the endoscopy in the preoperative part. Next come to the audiology. So first is the pure tone audiometry. At the same time, speech audiometry like SDS should be done, and tympanometry. Okay, and Raman sir will discuss the PTA or the audiometry after that discussion. So I am not going in depth of this audiological investigation. But why the audiology is important in a case of COSM? Because we have done our Rini, Weber and all the tuning fork test, and we have reached a diagnosis. Suppose these patients having a SN loss or a mixed loss or a pure conductive loss, and that should be proved or should be confirmed by doing a proper audiometry. And at the same time, the magnitude of the hearing loss, whether this is a mild, moderate or severe, or there is a SN loss component present or not, that should be known before going for the surgical or medical decision, because these things or this information will change your actual decision making during the surgical technique. Whether you are going for canal wall, down canal wall, everything is required to know what are the status of the hearing for the diseased ear. Next is the radiological investigation. So what are the radiological investigation? In our time, at the 10-15 years back, the major investigation were X-ray lateral oblique view, okay, of the mastoid to visualize the cell or the cellular structure and define the tegment tympani, posteriorly the sigmoid sinus and the external auditory canal to define the McQueen's triangle, etc. But day by day, as the advancement in the medical fields and availability of the CT and MRI are very easily accessible now. So now one of the most important investigation before a surgical management is the CT scan. HRCT of the temporal bone or HRCT of the temporomastoid region. So what is the role of CT scan here? The CT cannot diagnose actually. Suppose you have a shadow in the middle ear or the mastoid antrum and your clinical diagnosis is a cholesteatoma. So whether CT can say this is a cholesteatoma or not? Absolutely not. CT cannot differentiate between the shadows, between the cholesteatoma, polyp, secretions, brain tissue. CT cannot differentiate between the intensities. So For that we need the MRI. That I will discuss after that. So the role of CT more or less is to define the anatomical limits. The points should be noted, whether the jugular bulb is high or not, sigmoid sinus is more antepost or not, what is the plane of the your middle cranial fossa, okay, is there any complications? If there is a cholesteatoma's disease or is a squamous cell disease, there is any lateral canal fistula present or not. This is the more important to know in a CT scan. So CT is for the bony anatomical landmarks. Is the normal anatomy, or is there any deviation from the normal anatomy is there or not? Second, is there any complications or not? For CSM, one of the major complications is the labyrinthitis and the lateral canal or the posterior canal or the superior canal fistula. Most common being the lateral canal fistula, obviously into the path of the cholesteatoma growth, and the status of the ossiculation. So that can be defined with the help of CT scan. So previously one question was asked, what are the indication of CT in a case of CSM? First, in the pediatric patient, if the CSM presents in a pediatric patient, then CT is a must. If presents with any type of complications, whether intracranial, whether intertemporal, CT is must. Okay, so these are the two situations. And third is the revision surgery. If there is a history of previous surgery, then CT is the must, because if the OT nose is available or not, CT can define the extent of previous surgery or extent of bone drilling or bone loss, etc. So these are the actual important points for the CT. So always remember, CT cannot diagnose, CT can tell only the extent of the disease and the normal anatomical structure that should be known before going for any surgical management. Now the MRI. So day by day the use of MRI is increasing in every field of medical science, and this ENT is also, and the otology is also the very important part. So MRI of the temporal bone, in your case, in your long case, when it is necessary, it can actually define the disease pathology, whether it is a cholesteatoma or not. And the protocol used is non-EPI, non-echoplanar, DW, diffusion weighted MRI, non-EPI, DW, MRI. So basically there is a diffusion restriction. So that is used for assess the water content inside the disease or the pathology. So it can differentiate, this DW8 MRI can differentiate the cholesteatoma from any other mucosal polyp or the mucosal disease or secretion or bent tissue, etc. And the size of the cholesteatoma that can be defined by the use of this DW8 MRI. And why this is important? Before going for the surgical, as nowadays endoscopy has a big role in the cholesteatoma surgery also. In the limited attic cholesteatoma, we can use the endoscopic approach also. So in that case, to define the disease pathology, whether it has been crossed the adductus or goes inside the antrum, or it has been crossed the lateral semicircular canal, that can be defined by the DW8 MRI, and that is a very important factor for deciding the approach, like inside out or endoscopic approach. Okay, so this is the role of MRI. At the same time, I have already mentioned, if there is a complication, suppose a patient presented with a complication, any type of intracranial complication, intertemporal complications, then this MRI is also useful, because whether there is a pus accumulation inside the brain, is there an abscess or any meningitis, that can be defined by the MRI. So these are the investigation or workup we should do before going for surgery. One more thing is the bacteriological culture. When it is important, if there is a active stage of the disease, whether it is active mucosal or active squamous, and we want to implement some antibiotics or going for the surgery, before that you can culture the pus for the bacterial or the fungus. If there is any type of bacteria and no is sensitivity, so it can actually direct your management, what kind of management you want to do. So these are the actual tests. Apart from that, we can do the blood test and everything, that is just before the surgery, to know the candidacy of the child or the patient, so go for the surgery. So I think these are the actual investigations part, and then we can proceed to the surgical part when we have done all the investigation, and sir will take all the classes for the surgery and the surgical techniques.
গুড মর্নিং ঠিক আছে ওখানে ফোন আছে আমার Good morning, everybody. I think you have come from different parts of our state. Thank you for the trouble you have taken. I also thank association for giving me the opportunity to be here. I will start from Orindam. The importance of MRI. Yes, definitely the importance of MRI is very much. He have mentioned a few complications such as meningitis, brain abscess and others. Another important point you must know, that is meningoencephalosis. Very sorry. Meningoencephalosis. Meningoencephalosis. When there is a breach of the dura, please, sorry for this. When there is a breach in the dural plate, there will be meningoencephalosis. And MRI is very important to assess the size of the meningoencephalosis. When it is very short, when it is very limited, you can retract it, within the push it. But in larger cases, you have to cauterize it and leave it within the cavity to act as that will prevent further infection in future. Okay, however, the most important aspects of chronic suppurative otitis media is audiometry. You have to do pure tone audiometry, and in some cases, caloric test is also required. So, for pure tone audiometry, as when a patient comes to you, you advise pure tone audiometry and tympanometry. When you will advise audiometry? It is a wet ear or it is a dry ear? My question to you, when you will go for pure tone audiometry? In dry ear, yes. In dry ear, actual deafness you will get. And in some cases, complications, when there is a complications, such as there is a labyrinthitis, such as the patient is having vertigo and others, you have to go for audiometry. The frequency in which you will start audiometry? Huh? Anyone? 1000 hertz. It is 1000 hertz. It is 1000 hertz. It is not 250. Definitely will come down to the 250, but the first frequency is 1000 hertz. You have to accustom the patient in that frequency. Subsequently, you come down in the lower frequency. Now my question is, what is mid frequency? What is mid frequency? What is mid frequency? When you are in doubt that the patient is not audible to that particular frequency, such as you have tested you are now testing the patient. Okay. You are testing 4000 hertz. 4000 hertz. But you are in a doubt whether the patient is audible to that particular frequency or not. In that case, you have to use 3000 hertz. As it is jump in octave, 1000, 2000, 4000. But mid frequency is mid octave is necessary, 3000 hertz, when we are doubt that 4000 is not audible to that particular patient. we will use 3000 hertz. Okay. And now my favorite, my favorite question is, what is recruitment? What is recruitment? Anybody? What is recruitment? And what is the test of recruitment? Recruitment is an abnormal phenomena. When there is a slight increment in the intensity of the sounds, it will produce an enormous increase in the subjective sense of loudness. It occurs in sensory type of hearing loss. So recruitment is an abnormal phenomena. When there is a slight increment in the intensity of the sound, it will produce an enormous increase in the subjective sense of loudness. Okay. It occurs in sensory type of hearing loss. Next, my main chapter is surgery. I will first come in the tympanoplasty, although the time is very short. We use two types of grafts. I am not going in details of that in tympanoplasty, where you are used to take temporalis fascia. I will mainly concentrate on the cartilage tympanoplasty, but before going to the cartilage tympanoplasty, what is the complications of fascial graft? What is the main complication of the fascial graft? These are not complications. This is a sequelae of the surgery. Pain is not. Medialization or lateralization? No? Okay. Any other complications? Iatrogenic cholesteatomy is one of the complications. Iatrogenic cholesteatomy is one of the complications of fascial graft. It can occur in cartilage tympanoplasty also, but iatrogenic, when you are lifting the skin from the anterior canal wall, and the main sites of iatrogenic cholesteatoma is anterior canal wall. Next is I'm going very fast. Next is our cartilage tympanoplasty. Cartilage. And what is the diameter of the cartilage? What is the ideal diameter of the cartilage? Ideal diameter. It is less than 5 mm. It is less than 0.3 to 5. If it is more than 5 millimeter, then the high frequency sounds will be less audible to the particular patients. Although we have advantage of cartilage tympanoplasty because it will give much more stability in comparison to the fascial graft. But the actual diameter will be 0.3 to 0.5. Never it will be more than 0.5. Now, how we will place the graft? Cartilage tympanoplasty is not the only answer. Cartilage tympanoplasty, the cartilage must be associated with perichondrium. And the size of the cartilage must be, it will be in such a shape that it fits in the size of the perforation. It should not be larger. It should not be larger than the perforation. It must fit in the size of the perforation. So this is the cartilage tympanoplasty. Otherwise, if we take the cartilage, it will interfere in the hearing. Next is, we'll go for our mastoidectomy, which is our bread and butter nowadays, canal down mastoidectomy. Okay? Canal down mastoidectomy, whether you will go for one-stage mastoidectomy or second-stage mastoidectomy. What is your preference? Single stage. What is the disadvantage of single stage and what is the advantage of disadvantage of second stage? There is advantage of the second stage also.
Sir, in case of usually in case of adults we do single stage. In case of child, we do double stage. Like
Okay, okay. But the second stage has the advantage too. The single stage, there is definite time. I will finish it right now. This second
We
stage.
can, in second stage, we can have a closer look at the disease. If any recurrence has occurred or not, we can inspect in the second look procedure.
Yes. If there is an adherence of the cholesteatoma matrix in the vicinity of your windows, oval window or round window, if it is close to the facial nerve, then sometimes we have to go for second stage. As in second stage, when there is a inflammation is less, when the infection is less, it is easy to identify the matrix. And we can remove that. In a non-infected cavity, the removal will be easier. But the most disadvantage after the first stage, the structure, identification of the structure is also difficult. Okay. This is the advantage, and this is very short. Now, what is the definition of the radical mastoidectomy? Radical mastoidectomy. What is radical mastoidectomy? If examiner asks you, this is the what is radical mastoidectomy?
so, it's a surgical procedure where middle ear the mastectomy is done. Then canal 1 down procedure is done, and the middle ear cavity and mastoid made in a single cavity with removal of all the mucosal layer with ossicles with closure of the eustachian tube.
Radical mastoidectomy is an operation where it is middle ear cavity and the mastoid cavity both converted into a single smooth accessible cavity. Single, smooth, accessible. Three adjective is there. Single, smooth, accessible cavity by doing a wide meatoplasty. So this is the definition, but we must keep the stapes, at least the stapes foot plate, or where the step is intact, we don't disturb the stapes for future reconstruction of the hearing. Okay? And so this is in short of the surgical treatment. Otherwise, how will you use the, what is the, from where the mastoid segment of the facial middle starts, the facial nerve starts in the middle ear, mastoid segment, where it starts, the mastoid segment of the facial nerve, second genu, from the second genu, which is anteroinferior to the semicircular canal, and it begins in the middle ear from the cochleariform process. These are all there. And how will you use the bar over the facial nerve? Large size bar, you will use the facial nerve, not very sharp one. With this, I will finish my discussion.
These were only the guidelines of how should you go for surgery and how will you go for audiometry and what will the points you will consider while doing audiometry and surgery. But if you have any other question, they will definitely have many other questions, and Sir will be here to answer all your questions and clear all your doubts. But the question the examiner will ask next is, what will you do with this patient? কি করবে? হ্যাঁ, ইনভেস্টিগেশন হয়েছে, ইনভেস্টিগেশন করেছো, ইনভেস্টিগেশন যদি নাও হয়ে থাকে, তোমার এখন যা ফাইন্ডিং আছে, depending on the clinical finding you have now, what will you do with this patient? And whenever you think about surgical aspects or decision making, what will you do? Always consider about the choices of the patient and the requirements of the patients. Try to talk to the patient. Don't go to your decision. Don't force your decision on the patient. So always the patient is a human being. যেটা কেউ বলে না, মানে 90% কেসে কিন্তু আমরা শুনি না যে কেউ বলছে যে আমি পেশেন্টকে বলবো। পেশেন্ট কাউন্সেলিং, পেশেন্টের কি ডিমান্ড, পেশেন্টের প্রফেশন কি, এগুলো ভেবে আমাকে সার্জারির কথাটা ভাবতে হবে, নট অনলি অন দ্য স্টেজ অফ দ্য ডিজিজ। তো অ্যাকর্ডিং টু দ্য স্টেজ অফ দ্য ডিজিজ, অ্যাকর্ডিং টু দ্য ডিগ্রি অফ ডেফনেস, তোমার কাছে তো অডিওমেট্রি নেই, হাউ ডু ইউ নো দ্য ডিগ্রি অফ ডেফনেস? সিরিয়াল টিউনিং ফর্ক টেস্ট। তো এটা কতটা থাকলে তুমি মনে করবে যে দেয়ার মে বি অসিকুলার চেন ডিসকানেকশন। স্কট ব্রাউন কি বলছে? 35 ডেসিবেল অর মোর। ওকে, if there is more than 35 decibel of hearing loss, there is chance of ossicular chain disconnection. তো আমাকে এই জিনিসগুলো মাথায় রাখতে হবে। অ্যাকর্ডিং টু দ্য স্টেজ অফ দ্য ডিজিজ আই উইল কনসিডার দ্য ম্যানেজমেন্ট প্ল্যান। দেয়ার মে বি ডিসিশন যে আমি কি করব, পেশেন্ট কি আছে, ডিজিজ কি আছে, পেশেন্টের চয়েস কি, সেগুলোর উপর বেস করে আইদার দেয়ার উইল বি নো ট্রিটমেন্ট অর কনজারভেটিভ ম্যানেজমেন্ট অনলি, সার্জিক্যাল ট্রিটমেন্ট অ্যান্ড হিয়ারিং এইডস। সারপ্রাইজিংলি যেটা জানবে যে হিল্ড ওটাইটিস মিডিয়া, হিল্ড স্কোয়ামাস ওটাইটিস মিডিয়া, স্কোয়ামাস ওটাইটিস মিডিয়া হিল্ড মানে কি? রিট্রাকশন পকেট। হ্যাঁ, তো রিট্রাকশন পকেট, রিট্রাকশন পকেটে বিভিন্ন রকম সার্জারি আছে, সার্জারি করব কি করব না অনেক কিছু করা আছে, কিন্তু রিট্রাকশন পকেটে দ্য টিম্প্যানিক মেমব্রেন ইজ উইক, ইট ক্যানট ড্রাইভ, ইট লুজেস দ্য ড্রাইভিং ফোর্স অফ দ্য ossicular chain, so there will be deafness. And simple repair of the tympanic membrane of the by excising the retraction pocket is not going to help. So you will have to bring the driving force again. And most often, the Scott Brown says that most often the patients prefer hearing aid to surgery in retraction pockets. And surprisingly, there has been no study on the effectiveness of hearing aid in retraction pockets. Till now, there is no study available on the usefulness of hearing aid in heel otitis media. Now, এবারে আসছে যে আমি অন্য সাইজে এটা কি করব, ইনঅ্যাক্টিভ ডিজিজ অর অ্যাক্টিভ ডিজিজ। আমাদের কাছে যে কেসগুলো দেওয়া হবে অল আর অ্যাক্টিভ ডিজিজ। তো হাউ টু টয়লেট দ্য ইয়ার, অরাল টয়লেটিং, আমার আগে বা আমার সেন্টারে মানে এক্সটার্নাল যিনি এসেছিলেন, হাউ টু টয়লেট দ্য ইয়ার, এই কোয়েশ্চেনে মোটামুটি সবাইকে ঘোল খাইয়েছেন। হাউ টু টয়লেট দ্য ইয়ার, টয়লেটিং দ্য ইয়ার, ইউ ক্যান গো ফর ড্রাই টয়লেটিং। হোয়াট ইজ দ্য বেস্ট মেথড? আন্ডার মাইক্রোস্কোপ, suction clearance under microscope. You may also syringe the ear with clean normal saline in body temperature, or mixed, it may be mixed with antibiotic and steroids. So there are different ways. এবং WHO এর একটা বই আছে, WHO তো এখনো ক্রনিক ওটাইটিস মিডিয়া বলে না, WHO বলে ক্রনিক সাপোরেটিভ ওটাইটিস মিডিয়া। সো ট্রিটমেন্ট অফ ক্রনিক সাপোরেটিভ ওটাইটিস মিডিয়া, ওখানে ডিটেলসে লেখা আছে নর্মাল স্যালাইন কীভাবে তৈরি করবে বাড়িতে। একটা ড্রপার দিয়ে নর্মাল স্যালাইন কানের মধ্যে বাচ্চা দেবে, আবার ওটাকে সাক করে নেবে। যতক্ষণ টার্বিড ওয়াটার আসছে ততক্ষণ তোমাকে বারবার ওটাকে ডিসকার্ড করে আবার নর্মাল স্যালাইন দিয়ে কানটাকে পরিষ্কার হতে হবে। ইট ইজ নট দ্যাট you cannot put water into the ear with a perforation. অ্যাবরিজিনাল অস্ট্রেলিয়ানদের মধ্যে, অ্যাবরিজিনালদের মধ্যে একটা স্টাডি হয়েছিল, আর সুইমিং পুলে ওদেরকে সুইম করতে দেওয়া হতো, অ্যান্ড দ্যাট রেজাল্টেড ইন ইমপ্রুভমেন্ট ইন দ্য কন্ডিশন অফ দ্য ইয়ার্স। তো একটা হচ্ছে অরাল টয়লেটিং কীভাবে করবে, হাউ উইল ইউ টেক আ সোয়াব অ্যান্ড হাউ উইল ইউ সেন্ড ফর কালচার সেন্সিটিভিটি, কখন করবে সেটা স্যার বলেছেন যে কখন তুমি ব্যাকটেরিওলজি করবে, কিন্তু ব্যাকটেরিওলজি স্যাম্পলটা কালেক্ট করবে কী করে, টিউনিং ফক টেস্ট কীভাবে করবে, কোন জায়গায় টিউনিং ফকটা হোল্ড করবে, কান থেকে কত দূরে রাখবে, ম্যাস্টয়েড প্রসেসের উপর কোন জায়গায় রাখবে, ম্যাস্টয়েডের উপর কোন জায়গায় টিউনিং ফকের বেস, ফুট পিস বলি, তো ফুট পিস অফ দ্য টিউনিং ফক কোথায় প্লেস করবে। এই জিনিসগুলো কিন্তু একদম সিম্পল কোয়েশ্চেন। স্যার জিজ্ঞেস করবেন যে হাউ উইল পারফর্ম রিনি টেস্ট, হাউ উইল পারফর্ম ওয়েবার টেস্ট। এবারে পেশেন্টের সামনে তুমি যখন বসবে, বসার পজিশনটা কি হবে, পেশেন্টের সাথে ইন্ট্রোডিউস করতে হবে নিজেকে যখন তোমাকে কোনো কেস স্যারের সামনে দেখাতে হবে, ঠিক আছে, এই জিনিসগুলো দেবে। এবং হাউ উইল ইউ ডিসাইড অন দ্য কোর্স অফ ম্যানেজমেন্ট, ইট মে বি সার্জারি, it may be canal wall down surgery, canal wall up surgery, tympanoplasty, ossiculoplasty, but everything should be dependent on your case. What is the stage of your case, what is the condition of hearing of that case, সেইটার উপর বেস করে তুমি বলবে যে আমি canal wall up, canal wall down, what are the advantages of canal wall up, what are the advantages of canal wall down procedure, but in long term there is no hearing difference in hearing status in canal up and canal wall down procedures in long term. কিন্তু ক্যানাল ওয়াল আপ ক্যানাল ওয়াল ডাউন প্রসিডিওর কখন করবে, কোন সময় আমার রেডিওলজিক্যাল ইনভেস্টিগেশন দরকার আছে? ইউজুয়ালি ওয়েন উই আর গোয়িং ফর ক্যানাল ওয়াল ডাউন প্রসিডিওর্স, রেডিওলজি সিটি স্ক্যান is not that important unless there is some complications. কিন্তু otherwise if I go for reconstructive surgery, endoscopic surgery, canal wall up surgery, কখন আমি staging করব? Staging of the surgery is important. If I go for an ossiculoplasty or reconstructive procedure in a second stage, the results are usually better. কিন্তু দেখা যাচ্ছে যে বেশিরভাগ জায়গাতে সারা পৃথিবীতে লোক মনে করে যে ওয়ান স্টেজ সার্জারি আমরা ট্রাই করব, ইফ ইট ফেলস উইল গো ফর সেকেন্ড স্টেজ, ইন এনি কেস উইল গো ফর সেকেন্ড স্টেজ। হ্যাঁ, তো বাট সেকেন্ড স্টেজ সার্জারি গিভ এ বেটার রেজাল্ট। ডিপেন্ড করছে যে আমার আইদার নো ট্রিটমেন্ট, পেশেন্টের এমন কন্ডিশন পেশেন্ট বাঁচবেই কম দিন, তার সিএসওএম নিয়ে আমি চিন্তা করবো না। তো এবারে পেশেন্ট বলছে যে না, আমি এই সাকশন ক্লিয়ারেন্স করে আমি রিট্রাকশন পকেট যেটা আছে, রিট্রাকশন পকেটটাকে আমি ডেবরি ক্লিন করে দিতে পারছি। ইফ কনজারভেটিভ মেজার্স is sufficient to allow an aged patient to lead a normal life with adequate social interactions, then I will go for that. এবং তুমি যখন কোনো সার্জারি করবে তার কমপ্লিকেশনস কী কী হতে পারে সেটা নিয়ে কিন্তু আগে থেকে পেশেন্ট কাউন্সেলিং ইজ ভেরি ইম্পর্ট্যান্ট। আমরা এরপরে বাকি যে জিনিসগুলো সেগুলো আসবো। টিম্প্যানোস্ক্লেরোসিস ইজ এ ভেরি ইম্পর্ট্যান্ট থিং। অসিকুলার চেন ডিসকানেকশন, টিম্প্যানোস্ক্লেরোসিস থাকলে কীভাবে, আরেকটা কোয়েশ্চেন, খুব সিম্পল আনসার, কিন্তু কেউ উত্তর দেওয়ার আগে চিন্তা করছে কি করব। মাইরিঙ্গোস্ক্লেরোসিস তুমি পাচ্ছ টিম্প্যানিক মেমব্রেনে, হাউ উইল ইউ রিমুভ দ্যাট মাইরিঙ্গোস্ক্লেরোটিক প্লেক? খুব সিম্পল আনসার, কিন্তু এটা নিয়ে এই ধরনের সোজা সোজা কোয়েশ্চেনগুলো কিন্তু হয়। ঠিক আছে, এরপরে আই উইল আস্ক প্রফেসর অধিকারী টু give you some tips about the pearls of management of chronic otitis media, and after that a very important thing is ventilation pathway of the middle ear cleft. That will be dealt with Dr. Das.
Good morning. Very short time. I am giving some tips regarding the question answered by the examiner, especially external examiner. When you answer all of the question regarding diagnosis and management of the patient, আমি টিপস দিচ্ছি খুব কম সময়, সব ফলো করো, বাড়িতে গিয়ে গো থ্রু ইট, পড়ে নেবে। এগুলো খুব ডিটেল বলা যাবে না, এইসব এত সব আমার 10 মিনিট সময় দিয়েছে। কোয়েশ্চেন অটোমাই চিনডেন, এটা জানবে, কোশ্চেনটা জিজ্ঞেস করে, এটা মোর অ্যাগ্রেসিভ, ক্যাভিটি প্রবলেম হয়, লার্জ ক্যাভিটি, সিভিয়ার ওটোরিয়া, বাট ফেসিয়াল নার্ভ প্যারালাইসিস, but facial nerve paralysis and lateral semicircular canal fistula are more common in adult than children. Okay. Management of intercranial complication, you know that what are the intercranial complication and what are the investigations to be done. But regarding treatment of meningitis, you must say antibiotic and steroid. I am emphasis on steroid. They will ask whether you will give steroid or not in case of management of meningitis. And in case of extradural abscess, always ENT surgeon will explode the mastoid and remove the granulation over the dura, evacuate the all pus and granulation tissue. But when granulation, you see some granulation is attached to the dura, don't try to remove that. The dura may be injured and there will be CSF leak. But intercerebral abscess, subdural abscess, always intervention must be done by neurosurgeon first. And when the patient GC will improve, then you will do exploration of mastoid. Okay, next. Symptoms and signs of raised intracranial tension. All you know, I mean last point I highlight করছি, slow pulse and subnormal temperature. এটা বলতে হবে, এটা মাথায় রাখতে হবে। All you know, ঠিক আছে? Pulse rate slow হবে and subnormal temperature. Stages of brain abscess, খুব সিম্পল লিখেছি আমি, সেন্সেফালাইটিস, স্টেজ অফ লোকালাইজেশন, স্টেজ অফ এনলার্জমেন্ট, স্টেজ অফ রাপচার, দেন সেরিব্রাল কোনিং অ্যান্ড ডেথ। কী করে রাপচার হয়ে সেরিব্রাল কোনিং হয় অ্যান্ড ডেথ হয়ে যায় পেশেন্টের, এটা জানতে হবে। ওই জন্য আমরা পেশেন্ট অ্যাবসিস থাকলে আমরা বলি না বেশি মুভ করাতে, করিডোর দিয়ে ঘোরাতে, বলে এক্ষুনি অ্যাডমিশন করো, পেশেন্ট মে ডাই এনি টাইম ডিউ টু রাপচার অফ দ্য অ্যাবসিস। ওকে, দেন এন্ডোস্কোপিক ইয়ার সার্জারি, এটা আমাদের বলবে এখানে তোমাদেরকে পরীক্ষার সময় জিজ্ঞেস করে, হঠাৎ অনেক সময় এমনি ওল্ড এক্সামিনাররা জিজ্ঞেস করে এন্ডোস্কোপিক সার্জারির ইউটিলিটি কী, এই পয়েন্টগুলো তোমাদের বলতে হবে। গেট আ ফিল্ড অফ ভিশন access to hidden areas, reduce need of post-oral incision, transcanal operation can be done, less morbidity. But limitation one hand technique, two-dimensional views in endoscope, longer learning curve, thermal damage, etc. Okay. Next, revision surgery, all you know, revision surgery খুব difficult, expertise is needed. Regarding revision surgery, all surgical landmarks should be identified, all bony overhangs should be removed. There is cavity problem can be reduced by cavity can be filled in pedicle flaps, solid metal like bone dust, chips can cartilage. Complication and complicating factor, all you know. Level of middle fossa dura, position of the sinus plate, these are the granulation tissue over the fallopian canal, fistula over the lateral semicircular canal. আমরা জিজ্ঞেস করতে পারি পরীক্ষার সময় যে তোমাদের কি কি কমপ্লিকেশন হতে কমপ্লিকেটিং ফ্যাক্টরগুলো কি তুমি খুললে কি কি জিনিস আইডেন্টিফাই করবে যেগুলো এগুলো মেক লিড টু কমপ্লিকেশন তা দিস আর দ্য পয়েন্টস এটা অনেক সময় জিজ্ঞেস করে এক্সটার্নালরা জিজ্ঞেস করে ইন্টারনালরা জিজ্ঞেস করে সিওএম উইথ সাদেন ফ্যাসিয়াল পলসি এটা তো পরীক্ষায় আসে কোশ্চেনও আসে দেখো যেটা আমি বলেছি গ্র্যানুলেশন হ্যান্ড টিস্যু অ্যান্ড কোলেস্টেরল এন্টার ইনটু দ্য বনি ক্যানাল latter is uncapped in the area of involvement. Granulation tissue surrounding the nerve is to be removed. If the granulation invade the nerve sheath left in place, if the segment of nerve has destroyed by the granulation, so resection of the nerve and grafting should be deferred till the fibrosis occurs. Okay. Cyanoid vertigo is management. Immediate admission, antibiotic therapy, vestibular sedative, HRCT, then exploration of mastoid either by modified radical or radical, then identify the fistula, size of the fistula, that is small, medium and large. Small is 5 to 1 millimeter, medium is 1 to 2 millimeter, large. Then the fistula should be repaired by fossa, pericardium or tissue glue with or without cavity obliteration. All you know, এখন এগুলো জিজ্ঞেস করে এটা আর বলছি না এটা পড়ে নেবে ককটা পড়ে নেবে ভালো করে পড়ে নেবে probability of leaving behind a residual cholesterol if cog is not removed that ক্লিয়ার তো ঠিক আছে কক অল ইউ নো এখন পড়তে হবে কক জিজ্ঞেস করে then corner septum anatomical variation prevalence of case reported to be 6.58%. তোমাদের পড়তেই হবে কেস না পড়লে কিছুদিন আগে আমি একটা পেশেন্টকে আমার পিজিডি করছিল কেস পেলো কর্নার সেপ্টামকে তুমি যদি পাচ্ছ কর্নার সেপ্টাম মনে হচ্ছে তুমি হাউ উইল ইউ আইডেন্টিফাই দ্য কর্নার সেপ্টাম একটাই টিপস দিচ্ছি তখনই তুমি অলওয়েজ ইউ সি দ্য ক্যানাল ইউ সি দ্য লেভেল অফ দ্য অ্যানুলাস কর্নার সেপ্টাম অলওয়েজ অ্যাবাভ দ্য অ্যানুলাস মেইন যে অ্যান্টাল সেলস ইজ অলওয়েজ বিলো দ্য অ্যানুলাস ওকে এটা দেখে নাও এটা পড়বে দেন পুশাক স্পেস অল ইউ নো ইম্পর্টেন্স হচ্ছে ইফ ডিসভেন্টেশন রেজাল্ট ইন অ্যাটিক কোলেস্টেটোমা ওকে এটা আমাদের বলবে আর ছবি দেখিয়ে বলবে এই জায়গাটা আমি অত ভালো এখনো হয়নি আমি কিন্তু লাস্ট ইয়ার আমি এক্সটার্নাল এক্সামিনারকে জিজ্ঞেস করতে দেখেছিলাম এই যে রিগার্ডিং সাইনাস টিম্প্যানাম টাইপস অফ সাইনাস ডিপেন্ডিং অফ দ্য শেপ অফ দ্য সাইনাস ইট ক্যান বি 4 টাইপস ক্লাসিক্যাল কনফ্লুয়েন্ট পার্টিশন and restricted. Regarding depth, 3 types, type A, type B, type C. Type C is always deep and medial to the deep and medial and posterior to the fallopian canal. It is very difficult to approach this type C. What is futis? জানে কে কজন জানে what is futis? এগুলো সব কোশ্চেনগুলো আসছে এ থেকে ওয়ার্কশপ থেকে সবাই জানে তাই তো পড়ে নাও ইম্পর্টেন্স কি it requires drilling during cochlear implant surgery to gain approach to the scalar tympani and for insertion of electrodes এবার এই জায়গাগুলো তোমরা পড়ে নেবে সাবপিরামিডাল স্পেস এপিটিম্প্যানাম অ্যান্টিরিয়র এপিটেমিক স্পেস প্রোটিম্প্যানাম কাকে বলে এটা আমাদের পরে ছবি দেখিয়ে তোমাদের বুঝিয়ে দেবে হাইপোটিম্প্যানাম ঠিক আছে থ্যাংক ইউ এগুলো পড়তে হবে এগুলো কিন্তু এক্সামিনার যখন দেখে যে শেষের দিকে জিজ্ঞেস করবে আমি গতবার তার আগেবারও দেখেছি এক্সটার্নাল এক্সামিনার এগুলোর উপর জোর দিচ্ছে এন্ডোস্কোপি অ্যানাটমির উপর জোর দিচ্ছে জিজ্ঞেস করছে এবং এটা না বলতে পারলে খুশি হচ্ছে না, প্লিজড হচ্ছে না। এইমস থেকে একজন এক্সটার্নাল এসেছিল, সে এন্ডোস্কোপি অ্যানাটমি নিয়েই কোশ্চেন করে গেল। তোমাদের ভালো করে এটা জানতে হবে, ঠিক আছে? থ্যাংক ইউ ভেরি মাচ।
Sir has already starting the discussion, the endoscopic ear surgery. সময়টা খুব কম, 10 মিনিট 5 মিনিটের মধ্যে এন্ডোস্কোপিক অ্যানাটমি অফ মিডল ইয়ার করা খুব মুশকিল। একটু ছবিটাকে বড় করা যাবে? কতগুলো ল্যান্ডমার্কস যেগুলো রিসেন্টলি এন্ডোস্কোপিক ইউজের পর চেঞ্জ হয়েছে, সো উইল ডিসকাস দ্যাট পার্ট অনলি। ওকে ওকে, থ্যাংক ইউ, থ্যাংক ইউ। So this is a endoscopic view of the middle ear. So what are the parts? The mesotympanum, and around the mesotympanum, superiorly the epitympanum, posteriorly retrotympanum, inferiorly hypotympanum, and anteriorly the protympanum. The retrotympanum and the protympanum that had been completely revolutionized after the use of endoscope. So in the posterior part, the retrotympanum, that has been divided into the two parts, the superior retrotympanum and the inferior retrotympanum by the subiculum. So here is the oval window area, this is the round window area, round window niche. So in the round window niche, there is a three part. One is tegmen, this is the tegmen, the angle, and this is the posterior pillar, this is the anterior pillar. So this starts the anatomical differentiation of the retrotympanum. This posterior pillar, when continues up to the styloid eminence, this is the part of the styloid eminence, this is called subiculum. So S for S, promontory to styloid eminence is the subiculum, promontory to pyramid is the ponticulus, and from the anterior pillar to the hypotympanum area, there is a ridge that is called funiculus. So the three important bony landmark, the ponticulus, the subiculum, and the funiculus, and one more into the anterior part, that is the proteniculum in the protympanum. Okay. So first is the subiculum divides superior retrotympanum and the inferior retrotympanum. This superior retrotympanum has 4 sinuses or 4 recesses. This is very important for the endoscopic anatomy as well as for the microscopic surgeons going for cholesteatoma surgery or the retraction pocket surgery. Now here will be the facial nerve. So I will go into the next image. This. Okay, so this is a diagrammatic representation of that area. This is the facial nerve that divides this part into the medial part and the lateral part. So medial part above the ponticulus, this is the posterior tympanic sinus, and in endoscopy we termed as these processes subpyramidalis or subpyramidal sinus. Okay, just below the pyramid, when there is a pneumatization, posterior part of the stapes below the pyramid, here is a small recess that is called subpyramidal space or subpyramidal sinus, and below that is the sinus tympani, the most important part into the recesses. So what are the part in the sinus tympani? Superiorly by the ponticulus, inferiorly by the subiculum, and posteriorly by the facial nerve, and this part. Actually this is the middle ear or the mesotympanic or tympanic aspect of the facial recess and the sinus tympani. So what we learned, the anatomical orientation and anatomical boundaries with the facial nerve, chorda tympani, fossa incudis for the facial recess, this is the mastoid part. So when we see from the mastoid part, that was the anatomical conception, and here it is bounded superiorly by the ponticulus, inferiorly by the subiculum, and posteriorly by the facial nerve in the laterally. So this recess is the sinus tympani, and sir already mentioned there is the 4 type according to the shape and the 3 type according to the extent. So the extent is more important because the disease pathology that go inside the sinus tympani, that is by the extent, and this extent classification can be done by the endoscopy as well as by the CT scan. The CT scan can easily define whether the sinus is deep and go beyond the facial nerve or the middle border of the facial nerve. Okay, so this is the sinus tympani. So medial part, subpyramidal sinus and the sinus tympani, and lateral to this number 3 is the facial recess between the lateral or incus buttress and the chorda tympani. This part is the facial recess, and just below it, above the styloid eminence, is the posterior tympanic or lateral sinus, lateral tympanic sinus. In the majority of patients, these are the very rudimentary space. The major pneumatization will be the facial recess and the sinus tympani. Okay. So this is the superior retrotympanum, more important for the cholesteatoma surgery. But thus below it, divided by the subiculum, is the sinus subtympanicus. That is bounded anteriorly by the round window, posteriorly by the styloid eminence, inferiorly by the funiculus, and superiorly by the subiculum. Okay. So here 2 or 3 important landmarks. Already we have discussed the fused teeth. What is fused teeth? Fused teeth is a bony landmark that goes from the styloid eminence to the round window niche area, is a bony prominence. And above the fused teeth and below the fused teeth, there is some cellular area that is called area concamerata. Area concamerata. Okay. So I'll go by this picture. I get picture. This elevation is the fused teeth. And here will be the some cellular tracts, superior and inferior to the fused teeth. This is called area concamerata. And just below that, there is the infracochlear canaliculus. Why this is important, this infracochlear canaliculus? This is also a hidden space for the cholesteatoma. If there is a mesotympanic cholesteatoma involving the retrotympanum, that might go into the infracochlear canaliculus and may reach up to the petrous apex. As well as this is a corridor for the skull base surgery. Infracochlear approach to the petrous apex can be reached by this infracochlear canaliculus. So these are the latest anatomical concepts of the endoscopy of the middle ear. And beyond the funiculus, here is the hypotympanum or the hypotympanic ear cell. In normal cases, there are some constriction or this prominence of this ear cell, and in some cases, if there is a flat and the jugular bulb is very high, so that may come up to that part. Okay. So jugular bulb can reach up to the round window, and recently we have came across a case the jugular bulb reached up to the stapes foot plate, the completely obscuring the round window area. So this is the high jugular bulb area, and anterior to that there will be the eustachian tube or eustachian tube area. Okay. Thank you. So before going to the ventilation folds, just we are talking the epitympanum. So there is a posterior epitympanum and the anterior epitympanum that is divided by the cog. So cog is a bony structure or the projection that comes in the sword note also. This comes from the tegmen and come across the epitympanic cavity up to the processus cochleariformis. So there is the cog divides the anterior and the posterior epitympanum. No, okay. So after this retrotympanic anatomy, we will just discuss the ventilation folds or the mucosal folds. Actually, this is a very complicated anatomy. In every book, that has been enormous description of the ventilation folds. There are so many folds are there, and they are so complicated for us to memorize and to use in our practical field. Because whenever we are going for surgery, all the folds are inflamed, and it is not possible to actually identify each and every fold. But few structure we have to understand. What is the fold? The folds are basically the junction of the succus, anticus, media, superior and posterior. When the succus in the embryonic life, they joins together, in the joining line, there are some mucous membrane, and these remnants of the mucous membrane is basically the folds. They may be composite, they may be simple. In cases when the folds are used to suspend the malleus and the incus, so suspending the ossicular chain from the epitympanum, these folds actually helps that. So what are the ligaments? This is the lateral malleolar ligament. Just identify this part only. So this is the ligaments: lateral malleolar ligament, anterior malleolar ligament, tensor tympani, and this is the posterior incudal ligament. These 4 ligaments helps to suspend the whole ossicular chain from the epitympanic roof. Okay. Now, along these ligaments, there are some folds in between, and these folds are: this is anterior, this is posterior, this is lateral, this is posterior part, anterior, posterior. So this is the anterior malleolar ligamental fold. This is the lateral malleolar fold. This is the lateral incudomalleolar fold. So these folds are very important to differentiate the epitympanum from the mesotympanum, and this is called the epitympanic diaphragm. So what is diaphragm? Diaphragm in our body is divides the thorax from the abdomen. So in middle ear, in the tympanic cavity, this basically differentiate the epitympanic cavity from the mesotympanic cavity. And this is called the epitympanic diaphragm that is formed by the ligaments and some folds. So this is the lateral malleolar ligament, this is the anterior malleolar ligament, this is the tensor tympani, and here is the posterior inguinal ligament. In between, there are the mucous membrane that is termed as the fold. So just memorize these names only, and this is basically used to differentiate both the cavities. Now, this term is the epitympanic diaphragm, and then what is the isthmi or isthmus? So there are some openings in the diaphragm that helps to communicate the ventilation pathway from the mesotympanum to the epitympanum and ultimately into the mastoid cavity, and that is the isthmus. So isthmus is the door and the actual diaphragm is the main differentiating point. So through the isthmus, there are three isthmus. One is the anterior isthmus and one is the posterior isthmus. So anterior isthmus is just medial to the ossicle, posteriorly bounded by the incudostapedial joint and anteriorly by the processus cochleariformis and the tensor tympani. So this part is called the anterior isthmus or isthmi antigus. Okay, and just below, just behind that, behind the incudostapedial joint, above the stapedius muscle, and this area is the posterior fold, posterior isthmi. Okay, so this isthmus, anterior and the posterior isthmus, actually used for the ventilation from the mesotympanum to the epitympanum. Okay, this is the classical ventilation pathway. Apart from that, there is also additional pathway that is called the anterior-most pathway, and this is the through the tensor fold. Actually, the tensor fold in the anterior part, anterior to malleus, okay, just below the anterior malleolar ligament. So in this fold, in the majority of the patient, the tensor fold is incomplete. So there is a small opening in the center of the tensor fold, and when this tensor fold is incomplete, there is a anterior pathway through the eustachian tube to the tensor fold to the anterior epitympanic space, and from the anterior epitympanic space to the posterior epitympanic space through the adytas and antrum to the mastoid antrum. Okay, so this is the anterior ventilation pathway. So if the tensor fold is incomplete, the anterior ventilation pathway is patent. If the tensor fold is complete, then the anterior ventilation pathway is not present, and in that cases the anterior epitympanic space is basically a blind sac without any anterior ventilation. The whole ventilation depends on the anterior ventilatory pathway or the classical pathway, the anticus and the posticus. Okay. Yes. So this is the ventilation pathway of the middle layer of the epitympanic cavity along with the mucosal fold. And one more thing is the Prusak space that already Viva sir described. The Prusak space is the starting point of the attic cholesteatoma. And what is the Prusak space? This is bounded superiorly by the lateral malleolar fold, medially by the neck of the malleus, and by the pars flaccida. So this is a triangle. So lateral malleolar fold, neck of the malleus, and the pars flaccida. So this part is, this triangle is the Prusak space. Okay. So how it communicates or how it ventilates? It is ventilated by the posterior pouch of von Trolls. So what is the posterior pouch of von Trolls? The posterior malleolar fold and the posterior malleolar fold ligament. Below that, there is a small pouch. This is called posterior pouch of von Trolls, and this actually communicates through the posterior most border of the Prusak space into the Prusak space. So if this is a very small space, and that is why majority of cases this posterior pouch of von Trolls is actually blocked, that leads to the loss of ventilation to the Prusak space, leading to negative pressure. So there is a retraction of the Prusak space and formation of the cholesteatoma. So this is actually the basics of the ventilation and the middle layer fold. Lot of things to be discussed, but now we are planning for the examination. So just keep your points in your mind. So what are the important points to be discussed, and during examination you should deliver these points only. So before going into a detailed discussion, keep these points in your mind. Okay. Now transferring the to Sam.
You will have many more doubts, and but we do not have adequate time. to discuss all those things here in the class. So you can send us your queries and we will give a written reply. Thank you.
And I will share the images in the your group. Okay. So nothing to worry. You can. সেগুলো দিয়ে দেবো আমরা সব WhatsApp.
This mucosal fold is discussed on your request. You have raised some issues that we should discuss about the mucosal fold. That's why I have asked to discuss this. So with this, we are concluding this COM. Thank you, Dr. Ramanuj Sinha sir, Dr. Somen Banerjee sir, Dr. Vibhas Adhikari, and Dr. Arindam Das.